Thank you, Kim. All right. Well, I guess we should go ahead and get started. It gives me tremendous pleasure to introduce our speaker for today. Boghuma Kabisen Titanji, or BK to most of us, is a Cameroonian-born physician scientist and an assistant professor of medicine here at Emory in the Division of Infectious Disease. She obtained her MD from the University of Yaoundé in Cameroon, where she worked as a medical officer after graduating, and then pursued postgraduate training in the UK. She got a master's degree in tropical medicine and international health from the London School of Hygiene and Tropical Medicine. She has a diploma in tropical medicine and hygiene from the Royal College of Physicians in London. And then she has a PhD in virology from the University College London. So at this point, I met BK when we were so delighted to be successfully recruit her to join the research track program in 2016. And so she completed a residency in internal medicine and then a 4-year fellowship in infectious disease. She was phenomenally successful as a fellow, which is not surprising given sort of that background and who she is for any of you who have met her. And while she started and continues to have interest in translational and clinical research in HIV, the COVID pandemic and now the monkeypox epidemic gave her opportunities to really even spread further. And also through that time, she really excelled at science communication. She already had, when she came, done a TED Talk and has a really remarkable blog, which emphasizes, again, one of her third interests, which is global health equity. So BK has become really a national and international recognized leader in many of these areas. And so it's a real honor to have her on our faculty now with us. Clinically, she practices both general infectious disease and cares for those living with HIV. BK, thank you so much for agreeing to update us on monkeypox, both the local and global perspectives on a re-emerging zoonosis.
Thank you so much, Wendy, for that kind introduction. It feels like a homecoming, and at the same time, I haven't really left home. So it's an absolute honor to be giving grand rounds today. I'll go ahead and share my screen and we'll get going.
That is not the view you want. That's the view you want.
Yes. So today I will be talking to you about the ongoing monkeypox outbreak, particularly focusing on the local and global perspectives of this re-emerging zoonosis. I have no personal disclosures, but I would like to advise the audience that this presentation does contain graphic images of monkeypox clinical lesions in humans. At the end of this hour, I'm hoping that the audience would be able to come away with an understanding of the historical context that has led to the reemergence of human monkeypox globally, and that I would be able to provide you with a local and global landscape of what the ongoing outbreaks look like. And finally, I would close out with giving you an overview of the clinical presentations as well as the treatment and prevention modalities that are currently available for human monkeypox. The ongoing outbreak of monkeypox started or was first identified in the United Kingdom in May of 2020. And over the 3 months that have since followed, we are now at over 62,000 cases globally, with over 104 countries reporting cases of monkeypox. Due to the growth of the cases and the way in which the outbreak spread rapidly, this triggered the WHO to declare a public health emergency of international concern in July 23 of 2022. So what is monkeypox and what is the monkeypox virus? I thought we'd start out with some basics on the virology of this pathogen. Monkeypox is a member of the orthopox virus genus, which is the same genus as smallpox, which is of variola, which is the causal pathogen of the now eradicated smallpox disease. It was first identified several years ago, although it's only causing an outbreak of global proportions now. It was first identified in 1958 in non-human primates that had been imported to Copenhagen for research. It is a double-stranded DNA virus, which has a very large genome that constitutes of about 200 kilobase pairs. There are two main strains of the virus, the clade 1, which is the virus strain that circulates primarily in Central Africa in the Congo Basin, and clade 2, which is the strain of the virus that circulates in Western Africa. Clade 1 has been associated with a higher mortality, estimated at about 10% of mortality when it causes infections in humans, and is more clinically similar to smallpox in its manifestations. Clade 2 is responsible for the ongoing outbreaks that we're currently witnessing. Now, pox viruses have a very complex replication cycle. They complete their replication entirely in the cytoplasm of the cells that they infect. And the virus is able to gain entrance into the cell by two main pathways, either directly by attaching to the surface of the cell and fusing with it, with the interaction between glycoaminoglycans on the surface of the cell and viral proteins, or by entering the cell through endosomal pathways. Once within the cell, it undergoes DNA replication, and essentially a formation of new viruses are made in this large variant manufacturing factories within the cell, and leads to two morphologically distinct versions of the virus. One which is known as the extracellular envelope virus that is released from the cell, and the other one, which is the intracellular mature virus that doesn't get released, but only gets released when the cell ultimately dies and lyses, and then can release that form of the virus. Both forms of the virus are able to establish infection in new cells. So what do we know about the phylogenetics of monkeypox? When you look at the genomes of monkeypox that have been isolated from the ongoing outbreak, and you compare them to the genomes of other known orthopox viruses, you would see that monkeypox clusters most closely with vaccinia and variola virus that causes smallpox. And when you think about its host specificity, unlike variola, which was quite specific to the human host, monkeypox tends to be less picky in what kind of host it's able to infect. And actually, infections have been described in humans, in non-human primates, as well as rodents and other animal species. The natural host of monkeypox is not fully defined, but it's thought to be small mammals of the rodent family that are endemic to countries in West and Central Africa. Now, coming out of the COVID pandemic, I know there's always a lot of interest around what does a virus evolve like, and whether when we're faced with an outbreak of a new virus infection, should we worry that the virus will evolve and will again be dealing with multiple strains like we have during the COVID pandemic. Unlike RNA viruses, monkeypox, as I mentioned before, is a DNA virus, and DNA viruses tend to have a much slower evolution rate. The evolution rate of orthopox viruses has been described as 1 to 2 single nucleotide polymorphisms a year in the entire genome. However, in the ongoing outbreak, initial genomes that had been isolated from patients who presented with monkeypox in this outbreak were found to have over 50 single nucleotide polymorphisms when you compared the genomes from the ongoing outbreak to genomes that were isolated from the outbreak in 2017. And in looking closely at these changes, it would seem that these changes have been selected under the pressure of human DNA editing enzymes known as ApoBecs, which suggests that although the outbreak was only detected in May of this year, the virus likely was introduced during the outbreak in 2017, 2018, and has likely undergone evolution in the human host undetected for a while before emerging on the global scene at the present time. We do not know what the full implications in terms of whether the mutations that have been identified in the genomes in the current outbreak, whether they improve the ability of the virus to transmit itself better, whether they have changed the pathogenicity of the virus. All those questions remain to be answered, but we do know that the virus appears to be evolving a lot quicker than it has previously before. So coming on to the second part of the talk, I would walk you through the historical context of how we got here. Now, the first human case of monkeypox was identified in the Democratic Republic of Congo in the early 1970s at a time when the World Health Organization was intensifying their push to eradicate smallpox. So there was intense case finding for smallpox-like disease to identify outbreaks and implement ring vaccination in order to eradicate smallpox. And it was during those intensive case findings that the first case of human monkeypox disease was identified in a young child, 9 months old, in the Democratic Republic of Congo. Over the 10-year period between 1970 and 1979, the outbreaks that occurred primarily were noted again in the DRC. There were few in numbers, and a lot of the individuals who were identified as having monkeypox infection in those outbreaks reported animal contacts as the potential source for their infections. A lot of these outbreaks were limited to less than 3 generations of transmission, and primarily affected children that were younger than the age of 15, and also secondary cases were most likely in unvaccinated parents and siblings. Now, fast forward to the next 10 years, looking at what happened to the outbreak between 1980 and 1990. Well, in 1980, we achieved the historical milestone of smallpox being eradicated from the human population. And that led to a discontinuation of smallpox vaccination in a lot of countries around the world, including in countries in West and Central Africa. So over the next 10 years, what we would see happen was continued sporadic cases and outbreaks of monkeypox that appeared to be happening with more frequency as we saw an increase in the population that was born without immunity to orthopox viruses because they had not received smallpox vaccination. And despite surveillance showing that there was a growing risk that monkeypox could evolve to fill the ecological niche that was left behind by smallpox, very little was done. Taking you forward to 10 decades after that, so now looking at the period between the 90s and the 2000s, there's this very important seminal paper that was published looking at the same health zone over a period of 20 years, comparing the number of monkeypox cases from the same health zone in the 1980s, and then looking at that same health zone in the mid-2000s. And that study, which was published in PNAS, showed that over a 20-year period, there had been a 20-fold increase in human monkeypox incidence in that health district. And it was also noted in that surveillance study that in individuals who were vaccinated against smallpox, they had a 5.21-fold lower risk of acquiring monkeypox infection. So what was driving the growing numbers of outbreaks and cases of monkeypox? I would say it's a combination of factors. With climate change, there have been more sort of ecological changes that have influenced the way in which humans interact with the animal populations, which probably has led to an increase in contacts between humans and potential reservoir animals. There's also been population growth in that time, as well as increase in human movement that has increased the likelihood of outbreaks that were often limited to very remote parts of West and Central Africa to have a route to become introduced into more densely populated areas. And the third and most important is that for a very long time, monkeypox was an infectious disease that primarily affected poor populations in forested areas of West and Central Africa. And it was never considered to be a problem that really was affecting the wealthy parts of the world, so it was neglected. And despite knowing that the problem was growing, very little was done to actually address it. And that's how we find ourselves with a global outbreak. In the third part of this talk, I'm going to go over some of the more clinical aspects of what we know about monkeypox disease. So how is the infection transmitted? On this figure, I've split the transmission to first of all talk about the classical transmission as one would expect to happen in endemic or historically affected settings. And then I would talk a little bit more about the transmission as we know it today. So in endemic settings, as I mentioned before, transmission has traditionally happened when humans get in contact with a reservoir animal or an infected animal species, either through hunting or through preparation of animals for food. And the index individual can then transmit the infection to close household contacts. Before the ongoing outbreaks that we're currently experiencing, there had been sporadic introductions of monkeypox into non-endemic settings. And I think the largest outbreak prior to this outbreak in the US was the outbreak in 2003, in which we had imported animals that were infected with monkeypox and led to infection of individuals who interacted or manipulated the animals. Now, once infection has been established in the human population, how does the virus transmit? This is really a virus that struggles to be an efficient virus in terms of how it transmits itself. It requires very close and prolonged skin-to-skin contact to be able to pass on from one person to another. Also, contaminated inanimate objects that have been utilized by individuals who have active infection with active skin lesions, such as their bedding, clothing, and such, can also be potential ways in which individuals can pass on the infection. Droplet and aerosol transmission is possible, but is considered rare. And you would think about this mode of transmission primarily in areas where ventilation is poor and there is congestion in terms of how people are sharing space, and that may favor aerosol and droplet transmission. In the ongoing outbreak, sexual transmission has emerged as an important mechanism by which monkeypox is spreading, and I will talk about that a little bit on a later slide. So how does it present clinically? The incubation period is anywhere between 4 to 17 days with a maximum of up to 21 days as described from historical outbreaks. Traditionally, there is a prodromal period during which individuals may have a non-specific flu-like syndromes such as fever, myalgia, fatigue, and headache. And then you have the rash phase where they develop a rash that evolves through 5 phases, which I have illustrated here. Initially starts out as a macule and then becomes more papular in nature. Although it's described as vesicular, it's not quite fluid-filled because it's a lot more thicker, meaty lesions. And then these lesions tend to have a central indentation called an umbilication, and then evolve into pustules, ultimately scabbing over and healing in anywhere between 2 to 4 weeks to resolve. There are certain characteristics of the 2022 outbreak that I think are very important for us to be aware of because they are distinct from what has been noted in historical outbreaks. Historically, as I mentioned before, the incubation period was anywhere between 4 to 21 days, and individuals tended to present with rash that could be on any part of the body. Solitary lesions were not typical, and the lesions characteristically were thought to be at similar stages of development. So if a patient presented with monkeypox, they would either have all their lesions at papular stages, or they might have them at the vesicular stage, or have them at the healing stage of scabbing over. The prodrome I described was also a common feature, and lymphadenopathy was one of the features that helped distinguish monkeypox from other papular viral exanthems. Now, fast forward to the 2022 outbreak. What is different? We've actually seen a shortening of the incubation period, as has been described in cohorts of individuals presenting with monkeypox in this outbreak. They present with primarily genital, oral, or perioral lesions, which have been quite predominant in the current outbreak. Solitary lesions have also been described with individuals sometimes presenting with just a single lesion on the oral cavity, on the skin, or on a genital region. And a lot of patients have also presented with mild polysymptomatic presentations with little or no prodrome, as had previously been described in other outbreaks. There are also isolated rectal presentations with individuals presenting with proctitis, as well as isolated pharyngeal presentations or oral lesions only. And lymphadenopathy is not always present, so cannot be reliably used as a distinguishing factor. So here are some classical images just to show you some of these, what these lesions look like. And in this initial figure, you see some of the perioral lesions that have that classic central umbilication. Now, looking at the oral lesions inside the mouth, on the tongue, you see this ulcer that could very easily be mistaken for a herpes ulcer or a lesion caused by syphilis. And again, you see some of these more atypical features looking like pharyngitis that can be mistaken for other diagnoses. And I think what I'm trying to drive home with these images is to really be aware of the spectrum of clinical presentations that we're able to observe with monkeypox, and have a low bar for suspecting that an individual could potentially have a monkeypox infection, even if they don't present in the classical way that you've read about in a textbook, especially given the fact that we are in an outbreak scenario. Here I show you some of the genital lesions that have also been described in this outbreak, and you can actually see that as the lesions evolve, sometimes you get, they can coalesce, and it's more difficult in those phases to actually make out distinct lesions. And this could also be mistaken for a variety of other cutaneous manifestations of infectious disease. And here you see a solitary penile lesion, which could be mistaken for a syphilitic chancre, again, re-emphasizing the need to think about the diagnosis and have a low threshold to send the appropriate diagnostics to be able to make a diagnosis. Here on this image, it just showing you a patient who presented with a nasal lesion, and again, showing you the progression of the lesion as it evolved through the days of presentation. And you can see that by week 2 in this particular patient, the lesions are quite necrotic. And when you think about a sensitive region as the face, you can imagine that this could lead to very severe scarring once the clinical evolution and the course are complete. So what are some of the complications that monkeypox infection can lead to? There have been a variety of complications described in the literature, and on this slide, I just highlight some of the more important ones. The skin lesions can become superinfected with bacteria, and some of the pharyngeal lesions can present with severe abscesses that compromise the airway, even requiring intubation. And we've had patients who have presented like with pharyngeal abscesses and airway obstruction requiring intervention by ENT, with the diagnosis of monkeypox only being made after the fact. Encephalitis is also an important complication and has actually already been responsible for several deaths across the world in the current outbreak. In pregnant people, monkeypox infections can result in miscarriages and stillbirths. And I mentioned before the crucial possibility of scarring, particularly thinking about the genital lesions that occur maybe in the setting of males who are not circumcised. We can see the formation of urethral strictures after the rash has healed, rectal strictures for those who present with proctitis and chronic pain syndromes. And obviously, death is the ultimate complication that can result from monkeypox. So in part 4, I'm going to go over some of the epidemiological characteristics of the current outbreak. So who is getting infected in this outbreak and who is most impacted by monkeypox? As I reported before, over 62,000 cases have been recorded globally, and it's affecting 104 countries that are actively reporting cases. There have been 24 deaths recorded to date, and there are a predominance of cases being reported remain in Europe and North America for the ongoing outbreak. The graph on your left-hand side shows some of the most prominent clinical presentations that have been reported. And a lot of patients do present with a rash, some present with a fever. And you can again see that the distinct feature in the current outbreak is the preponderance of genital lesions. 98% of the individuals diagnosed with monkeypox in the current outbreaks are male. And a lot of these individuals are males between the ages of 18 and 44, again, tracking very closely with other sexually transmissible infections. About 2% of those cases are women. And when you look at these granular data as provided by the WHO, the exposures that are reported by the female patients, of this number, about 66% are also reporting their primary exposure to monkeypox as being sexual contact. Fortunately, the case numbers in children have continued to stay low, although there have been reports, and to date, about 47 children under the ages of 4 have been diagnosed with monkeypox. And a striking feature that has emerged is that amongst the males that are reporting, 95% or thereabouts are actually men who have sex with men. And a majority of those, 43.2%, are also individuals living with HIV. So what does the outbreak look like in the United States? The US represents a third of the cases of monkeypox globally. And I just highlighted on this slide some of the countries that are reporting over 1,000 cases. In the US, there has been 1 recorded death to date, and the case numbers in cis women and children continue to remain low. 98% of these cases are in men, and very similarly to the global epidemiological landscape, a lot of these men, 95%, report their sexual orientation as MSM. So how do we diagnose monkeypox? The diagnosis is made by a PCR test, which is usually a lesion swab obtained from a patient that can be sent out for PCR testing, and a diagnosis is made if they are able to isolate the virus DNA. In the beginning of the outbreak, there was a lot of challenges about getting tested in the US because a lot of the testing was through the health department, primarily initially by a generic orthopox virus PCR, and then confirmation by the CDC. This has improved tremendously over the last 2.5 months with commercial labs now able to carry out testing, but we're still seeing very slow turnaround time with people waiting several weeks to get results, up to a week to get the results back when you send out testing. The test positivity rates remain pretty high, which usually suggests that we're probably not testing enough and can continue to do better in terms of identifying those individuals that need to be tested for monkeypox. So what about vaccination? And what are the prevention strategies that we have available for monkeypox? Orthopox viruses have a unique feature, or a feature that we are able to exploit as a way of preventing infection, in this case, monkeypox. They share immunologic cross-protection between viruses of the same genus, and this simply means that if you are infected with an orthopox virus or have been vaccinated by a vaccine based on an orthopox virus, like the smallpox vaccine, then the immunity that you get from that vaccination can confer some degree of protection against other orthopox viruses. And that is what is being exploited in this outbreak. And we are actually utilizing vaccines that were developed for smallpox to immunize individuals identified as being at a high risk for monkeypox infection. So before we go into the details of the available vaccines that we have to protect or prevent monkeypox infection, I thought it was important to give you a little brief summary of smallpox vaccines. The smallpox vaccines that we have available are based on another orthopox virus known as vaccinia virus. And this orthopox virus causes a way much more attenuated form of infection, but induces both humoral and cellular immune responses that are protective against variola virus. There have been several generations of smallpox vaccines. The first generation vaccines typically were developed by very crude cell culture methods, and were generally grown on the skin of live animals, notably calves, or grown in calf limb. And a good example of a first generation vaccine is Dryvax, that was used in the final years, sort of pushing towards the eradication of smallpox. These first generation vaccines had issues around the purity of the vaccines, but also had issues around the very severe adverse effects that they could cause, and were superseded by second generation vaccines, which are developed and with using more modern cell culture techniques, so have a higher purity and a better safety profile compared to the first generation vaccine. The second generation vaccine that we currently have available in the strategic stockpile is the ACAM 2000 vaccine. And lastly, the third generation vaccines are vaccines that are made from attenuated vaccinia, which is not replication competent. And this is the vaccine that has been widely used in the current outbreak. And some of you might be more familiar with it being called Jynneos vaccine. Now, based off of historical surveys, it is estimated that a lot of these vaccines, or at least the first generation vaccines, may confer up to an 85% protection against monkeypox. But although this figure is quoted so many times, I think it's important to point out that this estimate is based on one surveillance study that was conducted by the WHO at the end of the 1980s in 1988, and actually looked at household contacts of individuals who had monkeypox and compared the attack rate between vaccinated household contacts and non-vaccinated household contacts. So it's important to know that this study was small. It really only estimated the protective effects of first generation vaccines. And so we should be cautious with how we extrapolate these results to what that might mean for the second generation and third generation vaccines that are currently being used to vaccinate individuals at high risk for monkeypox. So zoning in on each of these individual vaccines, I'll start out with the live inactivated virus vaccine. As I mentioned before, this is the third generation vaccine. It is made using a replication deficient vaccinia virus strain that cannot cause an infection, and it was licensed in the United States in 2019. We do not have effectiveness data for monkeypox in humans for these vaccines, because a lot of the data that we have on these vaccines are based on human challenge studies in which, non-human primate challenge studies in which animals were exposed to monkeypox, and then the effectiveness of the vaccine quantified by comparing animals that had been immunized to animals that had not been immunized. And in these animal challenge studies, these vaccines were shown to be protective. It is a vaccine that is administered in 2 doses that are spaced 28 days apart. And the correlates of protection offered by these vaccines against monkeypox remain to be defined. Due to the global shortages that have plagued the supply of these vaccines, alternative strategies to administer the vaccine in a way that saves on doses have been approved. And currently in the US, the approach is to administer 1/5 of the dose in the intradermal layer as opposed to the subcutaneous administration, with the understanding that the intradermal injections would lead to exposure of a small dose of vaccine to the immune cells that are tightly concentrated in the uppermost layers of the skin and can amplify the immune response and still yield an immune response that is equivalent to vaccine doses that are administered subcutaneously. And these 2 administration strategies have actually been compared experimentally and found to yield at least the same level of immune response in healthy vaccinated individuals. It is worth noting that intradermal administration of the vaccine is associated with more significant local skin reactions. And in individuals with melanated skin who are predisposed to developing keloids, they can actually opt out of intradermal vaccination, which if they're worried that they could scar from this route of administration and actually go with the subcutaneous route of administration. There continues to be limited access to these vaccines, and vaccination primarily is being rolled out in North America and in Europe. So now moving over to the replication competent vaccines, specifically focusing on ACAM 2000, which is the 2nd generation vaccine available in the Strategic National Stockpile. It is based again on vaccinia virus, but this virus is replication competent and as such can cause an actual infection. It is administered using a bifurcated needle, which is shown on the figure here. And the tip of this needle is actually dipped into the vaccine, and the groove that you see there holds a drop of the vaccine containing the vaccinia virus. And the vaccination is administered by making 10 to 15 puncture marks on the skin of the individual receiving the vaccine, usually in the upper deltoid region. And what you're actually doing is you're making those puncture marks to break the skin and inoculate the virus into the skin so that it causes a local infection. And to know that the vaccination has been properly administered, individuals who are vaccinated develop what we call a vaccine take, which is essentially a pustule indicating the local infection with the vaccinia. And that generates the immune response that is then protective against the pathogen that you're trying to immunize against. It's worth noting that replication competent vaccines are associated with more severe adverse reaction and are actually contraindicated in individuals who have atopic dermatitis or have cardiac conditions, and have been associated with progressive vaccinia in immunocompromised individuals, as well as myocarditis and eczema vaccinatum in individuals who have skin conditions. So how does the inactivated vaccine, MVA, compare to ACAM 2000? There was this phase 3 trial that was published in 2016 in the New England Journal of Medicine, actually comparing the MVA vaccine to ACAM 2000. And in this study, they randomized 2 groups of healthy volunteers. One group received ACAM 2000, which is just a single vaccination administered by the scarification technique that I described in the previous slide. And the other group received the standard vaccination course of the MVA vaccine, which is given in 2 doses, spaced 28 days apart. And you can see that for both vaccines, within the first week following vaccination, there's barely any detectable antibodies. However, by the second week following vaccination, both vaccines yield an antibody response that is comparable. However, by the 4th week, individuals who have received ACAM have much higher antibody titers than those who have received Jynneos. And the individuals who received the Jynneos vaccine catch up on those antibody titers after they receive their second doses. And you would realize that these antibody responses tend to be comparable with each other and not in Jynneos vaccine is not inferior to ACAM 2000 after that 6-week mark. And I think that I wanted to show this slide primarily to highlight the importance of the 2 doses to really get to the levels of antibodies that are comparable to those received with 2nd-generation vaccines. I'm sure many in the audience have heard about individuals who received their first dose of Jynneos vaccine and develop post-vaccine immunization. It's not clear to what degree the protection you get from a single dose is protective against infection from monkeypox. So it's really important that even after that initial dose of vaccination, individuals continue to be careful in terms of using barrier measures or behaviors that reduce their risk until they're fully immunized by receiving their 2 doses of the MVA vaccine. So what are some special considerations that we need to bear in mind for these vaccines? They've also been used as post-exposure prophylaxis. And the thinking is that if you provide vaccination to individuals who have been at high-risk exposure to monkeypox within 4 days of that exposure, then you are still able to get them to generate an antibody response that may mitigate the severity of the infection that they develop or even prevent them from developing an infection. And this post-exposure prophylaxis can be administered up to 14 days after that high-risk exposure. Inactivated vaccines are safe to be used in immunocompromised individuals, be it individuals who are transplant patients or people living with HIV. But there is, however, insufficient data on these vaccines in pregnant persons. The vaccines are currently licensed primarily for individuals older than the age of 18, but can be used in pediatric populations, at least for the inactivated vaccines under EA IND protocols and in discussion with experts based on their recommendations. Replication competent vaccines are contraindicated in all immunocompromised individuals for the reasons that I discussed before. In the final part of this talk, I'll spend the remaining slides talking about the treatment modalities that we have available for monkeypox. There's unfortunately very limited options for what we actually have to offer patients who present with monkeypox medication-wise. And starting out with the antivirals, I think the antiviral that has the highest potential and that has been used a lot already under IND protocols is the drug tecovirimat. So where does this medication act in that life cycle that I showed you before? This is actually a medication that inhibits a virus protein called P37, which is important for the formation of the EEV virion, and in so doing reduces the production of these mature virions that are released from the cell. Its efficacy in monkeypox has primarily been demonstrated in animal models that have looked at, again, animal challenge studies in which animals have been challenged with monkeypox and then rapidly treated with tecovirimat. And in these animal studies, the medication has been shown to have an effect both in reducing the duration of the illness as well as the severity. It has a good safety profile based off of human studies, phase 1 and phase 2, but we do not have randomized controlled studies that demonstrate clearly whether this medication is effective against human monkeypox infection. There are anecdotal reports that individuals who have presented with severe illness, when given tecovirimat, report that they have some benefit in terms of less lesions or less pain or quicker resolution. But this really needs to be studied in a randomized control trial so that we have evidence that clearly demonstrates this. It is available in IV and oral formulation. The dosing is weight-based, and generally absorption of the medication is greatly improved by a fatty meal. The current prescribed duration of therapy is 14 days, but I would want to mention that 14-day duration really is extrapolated from smallpox, what we know about smallpox disease and the duration of smallpox infection. So although we are treating for 14 days, we do not also have clarity on whether this is the ideal duration for which we should be using this medication for. When individuals report adverse reactions, they complain about headaches, abdominal pain, nausea, and vomiting. And there's no reported teratogenicity based off of animal studies, but we do not have sufficient data in humans. Thankfully, there are ongoing clinical trials in the United States, in Europe, and also in the Democratic Republic of Congo that should help us answer some of the questions around the efficacy of this medication in the treatment of human monkeypox. The next group of antivirals that I would highlight here are brincidofovir and cidofovir. Both of these medications exert their action against pox viruses by inhibiting DNA replication. Again, they have been studied in vitro models as well as in animal models of orthopox virus infection and shown to have some benefit. But it's important to note that in the animal models that looked at both brincidofovir and cidofovir, they showed their impact or their beneficial impacts on the course of infection when they were given very early on in the challenge studies. So we're talking about human animal challenge studies in which animals are inoculated with monkeypox and then treated with the drug within 8 hours of exposure. And when you think about the clinical syndrome in humans, individuals that we are seeing in the clinic are generally presenting several days after their initial symptoms. So again, we don't have clarity as to what the true impact of these medications are in the treatment of monkeypox in humans. Brincidofovir is orally bioavailable and exists as a pill. Unfortunately, it's in very short supply and we can't readily access it for most parts. But when it is available, it is given in 2 doses that are spaced 1 week apart. It's important to note that there's embryotoxicity that has been reported based on animal data, and the medication is also associated with GI side effects, which can lead to it being discontinued in a small group of patients. Turning over to cidofovir, cidofovir is available in IV and topical formulation. It's currently not approved for use to treat orthopox viruses, but it can be considered based on expert advisory. And when it was used in animal studies, it was used at a dose of 5 milligrams per kilogram once a week over a 2-week period. It is very nephrotoxic, and to reduce some of that nephrotoxicity, it is traditionally administered with probenecid. Like brincidofovir, it has well-described embryotoxicity in animal models and is also associated with neutropenia, as well as decreased intraocular pressure and a variety of hypersensitivity reactions. So what are some of those outstanding questions that we really need to figure out about these antiviral medications? I already talked about the effectiveness of these medications and why we need randomized control trials, but also there is a question as to whether combination therapy has any role to play, particularly in individuals who present with very severe manifestations of monkeypox. There's also the question of antiviral drug resistance. Tecovirimat is very well described as having a low barrier to resistance, and in vitro studies selects for resistant mutants, drug resistant mutants, within 1 to 2 passages of the virus in culture. So again, very low barrier to resistance and a need for us to understand what this would mean clinically. Is there any role for these antivirals to be used either as pre-exposure or post-exposure prophylaxis? I think that this is an interesting question and one that hopefully future studies and clinical trials would help us address. The last treatment modality that I wanted to highlight is vaccinia immunoglobulin that is administered intravenously. Vaccinia immunoglobulin is essentially antibodies that are pooled from individuals who have received smallpox vaccine. And it has been licensed in the US for the use or for the treatment of disseminated vaccinia infections. Based on the literature, there really isn't any clear demonstrable benefit of vaccinia immunoglobulin given intravenously for the treatment of smallpox. However, in patients who are severely immunocompromised and present with severe manifestations of monkeypox, it is some medication or a therapeutic modality that can be considered and should be discussed with infectious diseases experts when you're faced with this unique clinical scenarios. Like with all the other medications I've shown before, we really do need studies that help us understand how best to use this treatment modality. And to close out on treatment, I really wanted to take some time and highlight the importance of adjunctive therapies. As I hope I have shown you so far, monkeypox, even when patients recover, can lead to very significant scarring and complications that they would have to live with for the rest of their lives. So it's very important to think about those adjunctive therapies that preserve the skin and provide good skin healing. Individuals present with itching and painful lesions. Think about using skin protectants like petroleum jelly, Sarna for itching, or calamine lotions. In patients who present with proctitis, you can also use local preparations of analgesic medications such as lidocaine or topical anti-inflammatory agents. And sitz baths can also help favor healing as well as improved perfusion to those areas that have skin that really needs to heal and scar properly. In patients who are presenting with pain, very important to control their pain. And also important to remember that even in individuals who are presenting with a lot of inflammation, steroids may not be the way to go, primarily because they would favor replication of the virus, but also because these lesions affect the skin. We need to remember that using corticosteroids would delay mucosal healing or the healing of the skin, and it's not ideal in treating these skin lesions. And I can't say this enough. I've learned so much from our dermatology colleagues. Important to engage their help early to really help with co-managing these lesions to ensure minimal scarring and healing for the patient. So where do we go from here? In recent weeks, I think there's been a cooling in terms of how much attention monkeypox has been getting in the media. And a lot of this has been due to the fact that we are beginning to see a decline in cases in the countries that started reporting on cases early on in the summer. And I think that the decline in case numbers is likely a combination of factors. With more education, there has been a behavior modification that has probably led to a decrease in the numbers of contacts that are resulting in infections. And also, there's some immunity from individuals who have gotten infected already with monkeypox, as well as vaccine-induced immunity as we continue to ramp up our vaccination strategies. Although these are very encouraging trends, I think it's always important to highlight the need to safeguard against complacency. When you think about an infection that is transmitted in a sexual manner, it's very hard to consider behavior modification approaches as a sustainable approach for controlling outbreaks in the long term. And we really should continue with educating the population as well as getting people immunized to protect a maximum number of individuals from getting infected in the first place. And of course, monkeypox doesn't end just because the case numbers are declining in Europe and in North America. I cannot close out this talk without highlighting the importance of a global response in actually tackling this global outbreak. Although monkeypox existed and was known to be an infection that caused human infections for over 50 years, it only became a problem when it started causing infections in high-income countries. And the response has continued to reflect that inequity. If you look at the numbers in the figure on your right, the 35 countries that are currently administering vaccines are countries that are found in high-income countries, whereas a highest number of deaths have been recorded in countries that are endemic for monkeypox. And so far as the inequities in the global response persist, the longer the likelihood that we would continue to deal with this outbreak for much longer than we need to. So what does that mean for the outbreak moving forward? That is going to be determined by our resolve to actually tackle it everywhere, and not only in the countries that are able to afford the tools that we have to address this outbreak. So I'll leave you with these final thoughts. I think it's important to remember that pox viruses are extremely successful pathogens, and almost every mammalian species has a pox virus that causes an infection in them. And smallpox caused more deaths than we can probably ever accurately estimate. We have the tools to control the current outbreak, but these tools only matter if we're able to get them to all those who need to be able to access these tools. Monkeypox is really getting an opportunity to launch itself on the global scene and really infect people in the human population. And when that happens with a virus, we worry about a virus adapting and getting better in its ability to spread. And I think that we can all learn a cautionary tale for what happens when we neglect zoonotic viruses. We know that HIV started out as a zoonosis, and we're dealing with it 40 years later. And COVID-19 is just the latest iteration. We can't let monkeypox follow the same path, and I hope that we'll do more to stop this outbreak in its tracks. And with that, I'll pass back on to Wendy, and thank you for joining. And again, thanks for having me.
Thank you so much, BK. That was fantastic. I can't believe how much ground you covered, really giving us the historical underpinnings and everything else. We're at the hour, but I want to ask one question that came from the Grady resident room who are listening, and was the first question that I got in. And it follows what you just said actually really nicely. So, you know, you started out talking about how this was a neglected disease that is not new to the global scene, or at least was not new in Central Africa. And you know, so the question is, there are obviously many other pathogens that could follow similar pathways. You've made the case for the importance of not neglecting neglected diseases. And so what structural and philosophical changes, like funding, communication, media, surveillance, need to be made so that we actually learn from this? And how do we thoughtfully partner with affected countries?
That's a very difficult question to answer in 1 minute, but I'll try. I think the first step is actually realizing that we are so interconnected in the way in which the world is currently interacts with each other, that an outbreak anywhere is an outbreak everywhere. And really, those resources, we should not only be thinking about making sure that resources are available anywhere when we are faced with these outbreaks, but need to think about these over in a more sustainable manner. And how do we do that? I think that it's important to invest in preparedness now and think about what is going to be the next big thing, right? If you have a list of pathogens that can cause global outbreaks of disease, what can we do preemptively now to make sure that we have vaccines and we have tools to combat these when they happen? And that we're making those tools not only for high-income countries, but really thinking about this as a problem that can affect anyone. And I think the way we do this is by ensuring that we build capacity in those countries where these pathogens are endemic, so that they too can be a part of producing these tools, so that they're not always relying on a donor model. So it's about investment, it's about recognizing our commonality as a connected world and about preemptively planning for these outbreaks before they happen.
I think Wendy has frozen. Thank you so much, BK. This has been fabulous. We really appreciate all the learning you've provided today.
Thank you.